in person. And yeah, hey, thanks. I have the honor to introduce our next couple of speakers. Next speaker is Sam Aitken. Dr. Aitken is a clinical pharmacist specialist in infectious diseases at Michigan Medicine, an adjunct professor at the University of Michigan College of Pharmacy. Go Wolverines. Dr. Aitken's research and clinical practice focus on infections in immunocompromised hosts with a special interest in multi-drug resistant bacterial infections. He is an author of the Infectious Diseases Society of America, Guidance on the Treatment of Antimicrobial Resistant Gram-Negative Infections, and the American Society for Transplantation and Cellular Therapy Guidelines. There's his bio, and I don't know if he's a Pisces Aquarius and likes long walks on the beach, but here's Dr. Sam.
For the record, I'm a Taurus, and I prefer mountains to beaches, but they're both fine. So anyways, I got the distinct privilege of presenting here. So thank you for the folks who invited me. I really appreciate it. It's nice to be out here. And so I have the distinct privilege of speaking on hot topics in infectious diseases for the last year. What you'll actually notice is that I'm presenting on 3 papers basically, and these are actually very recent. So these are, the request was for these topics to be super hot. And so I think these are as close to sizzling as a paper can be. So I'm going to go through, again, 3 papers that have recently been published that I think are very informative to infectious diseases and stewardship practice. It's a 25-minute talk, so I'm not going to be able to get into the nitty-gritty details. So for the my more detail-oriented pharmacist colleagues in the audience, I'm sorry, I will not be going through supplemental table 7. But I hope this is informative for you, and look forward to presenting. Let's see here. Okay. Let's see. These are my disclosures, so not relevant here. And then my objectives here. So these are the overall for this slide. These are new. These were not in there. Here are my disclosures that I put in there. And again, not relevant here. And then these are the objectives for this talk. So review a couple top manuscripts, highlight some key papers, and talk about late-breaking data from ECMID. So I think you'll hopefully enjoy these. So the first paper I'm talking about was, hopefully you caught this one. This was published in Lancet ID at the beginning of this year, 2024. And this was a nice randomized controlled trial called Simplify, nicely enough. How they got Simplify out of that title, I really couldn't tell you. I'm sure those letters are in there somewhere. But anyways, this was a nice randomized controlled trial of probably one of the cornerstone practices that we have in antimicrobial stewardship, which is de-escalation. We all do it, but is it safe? Is it worthwhile? Who knows? We don't really have data for that until this trial attempted to do that with a randomized basis. So why do this study? Again, this is a cornerstone of antimicrobial stewardship programs. This is something that basically every program is predicated on. We assume it's safe, but there's not really good evidence base to support the safety of de-escalation practices. And so the authors here hypothesize that de-escalation of antibiotics to a non-Pseudomonas agent, patients with bacteremia caused by a susceptible Enterobacterales, is non-inferior to continuing empiric drugs. For those of you in the room who don't understand or have not heard of non-inferiority trials, it's a very fancy statistical way of basically saying equivalency. So what they looked at is to see if it's equivalently safe to not de-escalating. So this was a prospective open label, that's important, non-inferiority randomized trial of patients in 21 Spanish hospitals with bacteremia caused by Enterobacterales, so E. coli, Klebsiella pneumoniae, whatever, who received an empiric anti-pseudomonal beta-lactam. And they were randomized 1-to-1 to either continue on what they got started on or switch to a defined de-escalation therapy. I'll show you that on the next slide, what that means. They excluded a whole bunch of patients, but notably patients who were neutropenic or patients with very prolonged planned courses were excluded. There are a number of other exclusion criteria that I'd encourage you to read the paper and take a look at. So what counted as de-escalation? We all have our sort of ideas as to what is a de-escalation move, what we think makes sense, what doesn't make sense. They created a little list, which was very nice, and they actually did these in ranked order. So if the organism was susceptible to these things, this was their order of preference. There are a couple of oddities here. So 1, ampicillin, 2, trimsulfa. we think of trimsulfa or Bactrim as an oral step-down option. They actually require that they use IV in this trial, which was a little bit of goofiness there. Trimsulfa for the non-pharmacist in the room is a real big pain in the neck to compound IV, and it comes with a lot of fluid with it. Cefuroxime IV was next, cefotaxime or ceftriaxone. In Spain, they have a Moxclav IV, which we do not have in the United States. So you can basically say is roughly equivalent to amsulbactam. Ciprofloxacin, again, IV for the initial phase. And then ertapenem was their last. After 5 days of IV therapy, so all patients had to get 5 days of IV therapy, they were allowed to switch to an oral therapy of their choice. And so this was basically the trial, and both arms were allowed to switch to oral therapy once they got 5 days of IV. So the primary endpoint was a clinical cure. So resolution of signs and symptoms with no modification due to either adverse reactions or poor response. And these were all assessed at the test of cure, which was day 3 to 5 after the antibiotic was stopped. I'm not going to go through all of these other sort of endpoints. You can read them on the slide. One thing that I think was pretty notable, though, is the reason why we do de-escalation in the first place is really not because we think it's unsafe or harmful from an adverse reaction standpoint for a patient to continue on, say, Pip/Tazo or cefepime. It's because we think that it'll decrease antimicrobial resistance down the road. Notably, the study was not powered and did not assess as anything other than a subgroup analysis in a limited cohort of patients whether this actually worked for what we want it to do. So that's already a big deficit with the data, is that we have no idea whether the reason we're doing de-escalation actually works for what we're doing it for. So with that said, they randomized about 300 patients to either get the de-escalation pathway or the control. This is, again, not a comprehensive listing of all baseline characteristics of the patients. These are just the things that I thought might be relevant and useful. So about a third of patients had a solid tumor of some kind. About a fifth or so were on some sort of immunosuppressive. The pit bacteremia score that you see here, this is a measure of severity of illness. These were not sick patients. 0 is as low as that score gets. So these were very stable, basically floor type patients. Some of them had septic shock at onset, but for overall, these were very moderately ill patients with bacteremia, predominantly a biliary source. We see all these patients all the time who get an ERCP and they have a brief little fever bout of sepsis and, oh, there's E. coli in their blood. But by the time that Stensic's changed, they're perfectly fine. So by and large, I think that's a pretty interesting thing to note about this study, is that these patients were very much not critically ill. Some key treatment characteristics, again, don't want to go through all of this, but you'll note that they were on antibiotics for about 2 days by the time they were randomized. So this is when the susceptibilities came back. They got about a week of intravenous therapy, and then about a total of 11 days of therapy overall. Most of these patients, probably consistent with US practice, received Pip/Tazo as their empiric drug of choice. Some were on carbapenems. And then over here on the left-hand side of the de-escalation column, you'll note what patients were switched to in order of preference. And despite this order of preference, hardly anybody got trimethoprim sulfamethoxazole. And that's because it's just such a pain in the neck drug to give people. So even though there was this preference built in, they didn't give it to patients, which I think is actually a reasonable thing to do. It was very silly to design a study like that, I think. But anyways, most of the patients, again, even despite the order of preference, most of them got ceftriaxone because people like the idea of giving a once-a-day drug versus ampicillin, which is 4 times a day. It's a bigger pain in the neck. What I thought was also interesting is that the oral therapies that they were switched to were very different in these groups. So predominantly the patients in the de-escalation group were not switched to ciprofloxacin, whereas the majority in the control group were. There was nothing specifying that they had to get these other drugs, but they were often switched to, say, the oral 3rd-generation cephalosporin equivalent or a Moxclav versus a quinolone. So considering some literature that suggests that depending on the type of infection, maybe quinolones are preferred for oral step-down therapy versus oral beta-lactams, that could also influence the results of this trial. But that's for another day and another discussion, not for here. So anyways, the outcomes, I don't think there's anything surprising in here whatsoever. I don't think any of us would have predicted up front that it was dramatically unsafe and patients would be switching to a susceptible drug. And that's exactly what was shown here. So about 90% of patients in both arms were cured. Microbiologic cure was over 90%. There was maybe a hint of a more recurrence in the control group. This was non-significant. There were hardly any deaths, again, consistent with a very non-sick population. hardly any C. diff. There was like one case in each arm, and adverse events were completely similar. So that's kind of it. There's nothing in this, and I don't think any of us would have thought. I don't think any of us would have thought, sorry, that this was going to be an unsafe practice. But and this just shows that resistance was identified in 15% in the de-escalation group, 23%. It was a smattering of ESBL type organisms, Stenotrophomonas. There was one carbapenem resistant organism in the non-de-escalation group. But this was such a small trial, it's impossible to make heads or tails of this. This does not provide us any meaningful information on the utility of this, just the safety. So there's no clear benefit to doing this. It just seems to be safe. So overall, I think this is a big trial. It's a step in the right direction. We need randomized data for things and good data for the things we do. So this is nice in that regard, but it doesn't, overall, I put this very firmly in the meh category. I don't think this is, it was a great effort, good to see, it's a step in the right direction, but it doesn't really, I don't think it changes practice in any way whatsoever. So anyways, that's all. Next, I think this one is a much more exciting study. This is the Bling 3 trial, and this is very much hot off the presses. This was published last month. Another randomized controlled trial that was many years in the making. And so for our colleagues in the room, how many of you, just show of hands, I don't have one of the fancy polls up, how many of you routinely use extended or continuous infusion beta-lactams at your hospital? Not as many as I thought. How many have actively decided not to do so? One brave soul. One. So, I'll be interested in your specific thoughts on this once I get through here. So this was a study done predominantly in Asia, Pacific, Australia. And so there's a lot of controversy surrounding the role of continuous or prolonged infusion beta-lactams in patients with gram-negative infections. Most of the previous randomized trials were not adequately designed or powered to assess this question. It's a difficult thing to study. But regardless of the data and your interpretation, it's very commonly employed in hospitals around the world. And so the question here is continuous infusion, note continuous infusion, superior to intermittent infusion, in other words, 30-minute boluses or durations for beta-lactam and antibiotics in patients with sepsis. And now for somebody point out a pharmacy resident to me. You, sir. Where do you think that continuous or extended infusion beta-lactams would be effective? Critically ill patients, and who else? So Mark Sheets, we have Mark to thank for that data, although he's stepped out of the room. Where else? Any sort of type of organisms that you'd expect it to be effective in? More resistant organisms. Perfect, thank you, gold star. Give him a break from rotation. Anyways, this was a prospective open label superiority. So this is not the standard non-inferiority study. It was actually a superiority randomized trial of patients in 104 ICUs, again, multinational study too, treated with either piperacillin tazobactam or meropenem with at least one or more organ dysfunction criteria and strongly suspected proven infection. So these were basically septic type patients. They received 1-to-1 to either get meropenem by a standard or pip-tazo by a standard infusion, 30 minutes, or a continuous infusion. The way they did the continuous infusion, they took the same dose they would have given people, added all together, and just infused that over 24 hours. This was a huge study, 90% power to detect a 3.5% mortality difference. This is absolute difference, so 3.5% reduction in absolute mortality from a baseline of about 25%. This was a huge study. Primary endpoint was death at day 90, and then a number of different secondary endpoints. You'll note clinical cure. And then the other thing I want to highlight here is the sort of component of the primary endpoint was the adjusted risk of death, adjusted for severity of illness, source of admission, and drug administered. We don't often think of trials including anything other than a direct comparison, but there's still confounders that can show up even in a randomized trial, and it makes sense to actually adjust for those things. So one of the portions of the primary endpoint was actually the adjusted thing. And as you'll see, that leads to a little bit of controversy with the interpretation of the study. Again, not showing everything, but for baseline characteristics, this was a huge study. This was about 7,000 patients who got randomized. You'll note here that these were a lot of patients in the ICU, typically coming from the ED or emergent surgery. The Apache score median, this is different than the pip bacteremia score, but this is a severity of illness measure. So roughly 22% of these patients would be expected to die. So in contrast to the last study, these were very sick patients. So these are the sort of patients that might benefit from an extended infusion. Most of them had pneumonia. Many of them were on pressors, about 70%. So these, in contrast, were very sick patients, the types of patients who would stand to benefit the most because they had the least physiologic reserve and ability to deal with their own infection. Herein lies the rub. So we talked about more resistant organisms being the ones that would benefit. The problem is, just like sepsis that we see, about slightly under half of patients actually had any organism identified. And then of those, overall, about 12% of patients had a gram-positive. We don't really think that those would be things that would benefit from extended infusion. A lot of them had E. coli, Klebsiella. It wasn't until you get to Pseudomonas is really where we think the money is going to be for these extended and prolonged infusions. Perhaps pneumonia, but E. coli and Klebsiella, if they're not resistant to the drugs, and when they're resistant, they're so resistant that there's no amount of beta-lactam you can typically give to them to account for this, or they're so susceptible that you can basically give whatever dose you want and it doesn't matter. So there's a very small smattering percentage-wise of patients who actually could have probably benefited from this upfront. So bear that in mind when you see the results. I think this was personally a study designed to fail. It had the same issue as the Mercy trial before, which I'm not talking about, but it's a similar issue, is that if you randomize patients with sepsis, that's pragmatic, it's practical, it's great, but not all patients with sepsis, especially if they're septic from like a viral pneumonia, the antibiotic does not matter. So it's not going to help how you deliver that antibiotic. But this is reflective of practice in that regard. And so here are the outcomes. And this is where people start to argue about this. And I've had many arguments about this study already. If any of you know Jason Pogue, you know that him and I do not agree on a single thing, even though we work together and have beer every Wednesday. It's a very nice relationship, but we do not agree on a darn thing. Anyways, all-cause mortality, slightly lower, minus 1.9% absolute difference. All these little ICU mortalities favor it. Hospital mortality favors, but these are not statistically significant differences. However, the clinical cure, higher. That's good. We like patients to be cured of their infections. That's very good. And new MDRO or C. diff, about the same. If you look at the adjusted mortality, which some people say this is a nonsense thing to do, I actually don't think it's a nonsense thing to do, and FDA says you can do it in trials. The P is 0.04. This P was 0.05. Or I'm sorry, 0.08, and one of the other analyses was 0.05. So this must have been like the razor's edge for these investigators when they got their stats back and just been frustrated. But this little 0.04 versus the 0.08 here is where people hinge on saying this is a positive trial versus a negative study. And I think this is one of these philosophical questions that people are going to have. To me, this is a ridiculously positive trial. Can you imagine an intervention that reduces the risk of death by nearly 2% in patients with sepsis? To me, it's a no-brainer. The number needed to prevent one death is about 50. So you have to give 50 patients an extended infusion or continuous infusion in this case to prevent them from dying. Why wouldn't you do that? What's the downside? You can also look here at time to discharge alive. So these patients leave the hospital earlier because you cure them more. And so cured patients tend to step out of the hospital faster than patients who aren't cured. To me, this is a very positive study. Yes, it's a small absolute benefit, but when you think if you're one of the 50 patients who's going to die, wouldn't you want this intervention? Like you're not even spending more money on the drug. It's a very no-brainer to me. So this is where I get a little bit Socratic with people. I interpret this as a positive trial. You, sir, who were the one person who actively decided not to do this, how do you interpret this trial? What is the applicability of this to prolonged infusion? Remember, this is a continuous infusion study, which is a different, slightly, you get better PK optimization than with prolonged infusion. They use the average dose of Pip/Tazo that was used in this study was a little bit lower than we'd expect. So 13 grams a day versus what we would generally recommend, which is 18 grams a day. So does higher dose Pip/Tazo negate this difference? What's the downside? And that's another philosophical thing that I posed a few times. And to get into these things, do we really need another 7,000 patient trial to get people to just do this very low risk intervention that is quite probably life-saving? I don't think so, but some people will call for it. And so the last thing I want to present, this is so sizzling hot, it's not even published yet. These are abstract data that were presented at ECCMID this last year in Barcelona in May. And so this is, can we use dalbavancin for Staph aureus bacteremia? Dots. And for the people from AbbVie in the room, I will be discussing off-label uses. Thank you. So dalbavancin, this was a study to establish the non-inferiority of dalbavancin to standard of care for Staph aureus bacteremia. And so this is a potentially huge thing for people in the room who are unfamiliar with dalbavancin. It's a long-acting lipoglycopeptide. And so you only have to give one dose or two doses, depending on what you're treating, to account for an entire course of treatment for, say, right now it's approved for cellulitis as a one-time dose. You can use 2 doses for osteomyelitis. This is a very practice-changing drug if this trial is successful, because it completely eliminates the need for prolonged hospitalization for Staph aureus bacteremia for IV antibiotics. So potentially huge implications. So why do this study? I mean, Staph aureus, how many of us have seen a Staph aureus case in the last week? I mean, I've seen like 3, and this was just, what day is it? It's Wednesday. So yeah, it's very, not even halfway through the week. So prolonged courses of IV antibiotics remain the standard of care. There's some, talk about switching to oral has become the new standard. So, but for purposes of this trial, the standard of care still is a prolonged course of IV antibiotics, sometimes 4 or 6 weeks. Long hospitalizations for people who inject drugs. There's very complex problems with disposition and what to do with them long term. And so the question is, can we clear out the ID wards or the general floors with dalbavancin, because it's a long-acting antibiotic? So this was a great trial, and it was a randomized trial of dalbavancin. 1 dose on day 1 of 1,500 milligrams, another dose on day 8 of 1,500 milligrams, and that's it. 2 infusions, done. Versus standard of care, which was 4 to 6 weeks of IV antibiotics with, either cefazolin, oxacillin, vanco, daptomycin, depending on whether they had MRSA or MSSA. These were patients with complicated Staph aureus bacteremia. So a number of things go into the definition, but it's unremovable source, greater than 3 days of bacteremia, persistent fever, a couple other definitions. But these weren't like the one and done, I can't treat Staph aureus as a contaminant, but this, if I'm ever going to, it's probably a contaminant, but I'm still going to treat it. It was not those sorts of patients. These were the patients who truly had Staph aureus bacteremia and were sick from it. They had to clear cultures within greater than 72 hours, so at least 3 days of bacteremia, but not be so persistently bacteremic that they were there for 10 days, lingering and languishing. So the standard of care there was, again, cefazolin, nafcillin, vanco, dapto. So the primary endpoint was what's called a DOR, which is a desirability of outcome ranking. So basically, this takes a whole bunch of different things together and puts them in a rank order of the things you want to or not want to happen to you. So for example, in this case, the worst outcome is dying. We don't like patients to die typically. And then there were basically a rank order of complications. So either clinical failure, a secondary infectious complication such as metastatic site of infection, something like that, or a serious adverse event. And basically the more of those you had, the worse your outcome was considered. So it goes from death to a whole bunch of adverse events to a few adverse events to no adverse events, and that's your ordinal scale right there. And so this assessed the clinical efficacy at day 70, and the incidence of adverse events were secondary endpoints. And so here, some baseline characteristics. This is not the large study, certainly not 7,000 patients. 200 patients were randomized to either dalbavancin or not. About a third had MRSA. About 16% or so in the dalbavancin arm were patients who inject drugs. Very, endovascular complications, about a quarter of patients, whether septic thrombophlebitis or other endovascular infections, about a quarter. Bone and joint, so osteomyelitis, and about a third. You can see here, these were the patients, we expect to see with Staph aureus bacteremia. Notably, the patients with left-sided endocarditis were not included in this. So that's a major limitation to this study, is that patients with left-sided endocarditis were not included there. The data is available in abstract form only, so this is basically what I got. I don't have any other additional information on you on this. Maybe if you harangue the people from AbbVie enough, they might be able to provide you secret insight into this study. I see you hiding in the back. So the outcomes here, the way you look at a DOR outcome is these sort of bar figures. Typically they're by convention, they're presented this way, like green is very good, red is very bad. For the colorblind folks in the room, the left side is very good, the right side is bad. So what you can see here is that those figures look about the same, the top and the bottom. That means this is basically the same outcome. So the patients in the dalbavancin arm seem to do just fine compared to standard of care. Not better. I don't think we were expecting this to be better, but it's certainly not worse. And in this case, in contrast to say Simplify, which where, sometimes you might even be switching to a more frequent drug per day. This is just game changing because you can get a patient 2 doses of a drug, completely cure them of the Staph aureus bacteremia, get them out the door. Like that to me is just remarkable. Now, it's not powered to say whether it's completely equivalent. This is a relatively small study. It's definitely not superior. And as I said, this is presented in abstract form. I think we learned our lessons the hard way with COVID, where if we start taking data from press releases and abstracts and all sorts of nonsense, we get ourselves into a bad way. So let's forget about that mindset that where somebody sends out a tweet and all of a sudden we give every patient a drug. Is we need to wait for the data to be published and determine what, the sort of holes in the data might be and all these sorts of things. But I am super excited about this because I think this has, if the data shake out as they seem to be, this has the chance to be huge practice changing implications for how we manage very complex patients. So anyways, wait for the details there. So those are the 3 trials I wanted to talk to you about. I could not possibly get everything in here. So here's a few other papers you should absolutely 100% read. Please do so if you haven't. The first is the Mercy trial. This is another study of prolonged infusion of meropenem. This was published in JAMA. It's a nice companion piece sort of to Bling. I think it had the same limitations, but it was much smaller. So that's why I did not present it here. Aitken is cefepime versus pip/tazo for adults with acute infections. This was another randomized trial presented in JAMA. This was the one that concluded that cefepime has increased neurologic adverse events relative to pip/tazo. I have very strong opinions on that. I don't think it's true. So anyways, I think this is another interesting one to read. This is a really nice retrospective study from the group at, this next one is from the group at Intermountain Healthcare in Utah. They did a really nice, well-designed cohort study of patients with gram-negative bacteremia who are transitioned to either oral beta-lactams or quinolones or trimsulfa. I think this is the most well-designed study that's available on this topic, and everybody should read it. It's very good. Come to your own conclusions on that. I don't want to tempt you. Then the last 2 are for the people in here who say stewardship is less antibiotics. These papers might make you cringe. But the next one is a study of a single dose of ceftriaxone for patients on the ventilator in the ICU to prevent VAP. And the take-home message from this is that you can give patients ceftriaxone to prevent VAP. So I recommend you read this study. That's something that particularly the people in ICUs may find interesting. It's a very interesting thing, makes you think outside the box, like maybe sometimes antibiotics are a good thing to give people. And then the last one is another one that is a VAP prevention study. This is not inhaled amikacin to treat VAP. This is inhaled amikacin to prevent VAP. And so this is also a very interesting body of literature, and I think this is a pretty definitive study on the topic that I think makes people think a little bit more about just the blind, oh no, we shouldn't give antibiotics to prevent things. We should only do them to treat things. I think these 2 last studies fit very nicely into a bucket that makes you think about why you're doing what you're doing and whether these might actually be good things. So anyways, in conclusion, I think 2024 has been a banner year for infectious diseases and stewardship research. Normally you do these best paper talks and there's like a whole bunch of like small retrospective cohort studies of 13 patients and you say, oh, this is wonderful. Now I had to like choose which randomized controlled trial I wanted to pick from, which is a really nice problem to have for this. And so I'm really happy we're finally getting pragmatic, applicable studies of these interventions. And then, especially with those last 2 that I put on that slide, but I think the data need to guide our approach rather than our presupposed notions about what needs to be the right thing to do for a patient. We're getting data, let that guide us. And then, just words of advice, especially for the trainees, actually cover your ears, multiply this number by 10. You should read at least 1 paper a week. The trainees, if you're not reading right now, you're doing it wrong. So read more papers. That's the other take home. And I think that's it. Do I have time for questions? I didn't see a timer here. Okay. Good. All right. Thank you.